Public perception frequently categorizes adolescent substance use as a behavioral phase. However, clinical data identifies these behaviors as a serious medical condition. During the critical period of adolescence, the developing brain is highly plastic, rapidly rewiring itself to organize complex neural structures. According to 2022 national survey data, 6% of U.S. adolescents aged 12 to 17 met the criteria for a past-year substance use disorder. The primary drivers are cannabis, nicotine vaping, alcohol, and prescription misuse. This 6% baseline represents a diagnosable medical condition. Managing it requires clinical protocols integrated directly into the K-12 ecosystem. Most school administrations default to detention or suspension when managing student substance use. These punitive frameworks fail to alter behavior because they do not address the neuropathological imperatives driving the use. Effective management requires replacing disciplinary rubrics with evidence-based diagnostic criteria. Our objective is to map established clinical diagnostic tools directly into K-12 operational workflows. Recognizing adolescent substance use disorder as a pathology is the prerequisite for deploying systemic interventions. The diagnostic standard for adolescents is identical to the one used for adults, the DSM-5 criteria. This dashboard displays the 11 clinical signs evaluated over a continuous 12-month period. Criteria include behavioral failures, like role failure at school or home, and abandoning social activities. It also tracks physiological markers, cravings, hazardous use, increased tolerance, and withdrawal. A mild diagnosis is defined by the presence of 2 to 3 of these signs. A moderate diagnosis requires 4 to 5 signs. A severe diagnosis is confirmed when 6 or more criteria are met. This rigorous grading matrix provides administrators with a path to manage substance use as a measurable, progressive disease. In an adolescent brain, these glowing nodes are rapidly firing, forming the branches of an interconnected neural network. This developmental state makes the brain highly susceptible to permanent addiction pathways. This graph illustrates the relationship between age and addiction. Earlier onset of substance use correlates with a higher probability of disorder persisting into adulthood. Every single year of delayed onset reduces the mathematical risk of a long-term disorder. Intervening early within the school system acts as a preventative measure for adult health. Establishing a diagnosis necessitates a shift toward evidence-based clinical responses. Treatments include the community reinforcement approach, cognitive behavioral therapy, multidimensional family therapy, and 12-step facilitation. Contingency management provides needed structure. Managing severe physical dependence may require medication-assisted treatment. For older adolescents with opioid use disorder, buprenorphine is the FDA-approved standard of care. Pediatricians identify these needs through SBART, a protocol for screening, brief intervention, and referral. While pediatricians conduct the screening, the school ecosystem is where these daily therapeutic modalities must be executed. Traditional K-12 budgets and personnel are generally not equipped to deliver complex clinical interventions. School-based telehealth infrastructure bridges the gap between clinical requirements and educational environments. This operational flow uses the MentalSpace school model to connect a central hub with the pediatrician, the campus, and the family. Dedicated therapist teams are assigned to individual schools, enabling same-day intervention. It integrates crisis intervention and protocols for suicide and violence prevention. Access is streamlined through $0 Medicaid and commercial insurance. The platform maintains HIPAA and FERPA compliance layers, supporting the 2026 deadline for Georgia's HB 268. This same pipeline also supports staff wellness and family counseling. By removing major financial and logistical friction, we allow these educational institutions to function as the primary sites for effective clinical healthcare. This represents disparate systems functioning together without friction. The impact of telehealth is visible in the measurable data of daily school operations. Data from the MentalSpace model shows a 92% reduction in student anxiety. This clinical improvement corresponds with an 89% increase in student attendance. Furthermore, the model has achieved an 85% family satisfaction rate. Addressing the clinical pathology directly impacts a student's ability to remain in the classroom. When the underlying anxiety and physiological triggers are managed, the primary drivers of absenteeism and disruption are significantly reduced. Effective management requires pediatricians to screen via expert and schools to provide the telehealth infrastructure to treat the results. Outdated behavioral management cannot resolve a disease defined by the DSM-5. District leaders can coordinate this integration through mentalspaceschool.com or by contacting the team at mentalspaceschool@chctherapy.com. Just like in construction, a complex grid of support allows for the creation of a smooth, unbreakable surface over time. Uniting precise medical diagnosis with frictionless, zero-barrier K-12 access creates a sustainable model for managing adolescent SUD.